Morning, Dr. Bass.
All right. Got fellows back from well-deserved break. Let's see. All right, when we get going. All right. Question here is what is the diagnosis and what is the treatment? So anybody have any thoughts about this tracing?
Good morning, Dr. Pass.
Good morning. Welcome back,
So,
Dr. D.
thank you. So this is well, normal standardized 12-lead EKG.
Yes.
The axis seems normal. It's a sinus rhythm with sinus arrhythmia. And treatment-wise, now treatment is a normal variant.
That's right. Good. Good. You found me out trying to trick you here. This is a normal electrocardiogram in somebody with basically sinus arrhythmia, which is a normal finding. Presumably, can you make any guess as to the age of the patient based on the tracing? Any clue to that?
Um, maybe somebody in teens.
Why do you say that?
Based on heart rate
Okay.
and also the progression of QRS in precordial leads, axis being normal as well, like around 60.
So is this an early teen or a late teen, do you think?
I'll say early teen.
Yeah, I agree. And I'm basing that on the T waves, right? As we grow older, our T waves flip up, and we still have an inverted T wave in V3. So if I were a betting man, I'd say this patient is in the 12 to 14 range, not the 16 to 20 range. Okay, good. You caught me trying to be deceitful here. Okay, this is an intracardiac tracing during an EP study. What is this arrhythmia and what should we do about it?
So in the intracardiac tracing, we see first the 12-lead EKG, like 1 and V1, which are showing
We'd say surface
surface
Yeah.
electrocardiogram, showing probably a wide complex QRS,
Mhm.
and the heart rate is high given the cycle length is 200 milliseconds, around
Mhm.
maybe around 200 or more than that. And the RR interval seems changing. In the high right atrium, we see more A's compared to the V's.
Yep.
And means given we have more A's than V's, either this is flutter or AFib, or
And you ferret out which of those it is. I agree with everything you've said so far.
maybe if AFib, given the RR, like irregular RR.
Okay, that's true, but is there any intracardiac evidence for that?
Like A to A, the rate is very high. Like
Right. And is it regular or irregular?
Irregular, sir. Yeah.
Wow. It's an irregularly irregular atrial rate. Like look at these A to A's are very, very tight. These are also tight, but much less so, right? These are roughly half the rate of some of these. So this is an example of atrial fibrillation with variable conduction. And what do we make of the fact that the atrial rate looks like this in the high RA, but look on the left side in the coronary sinus, the atrial rate is quite a bit slower. How does one explain that?
I think that atrial fibrillation, the rate can be different, different parts of the
That's
atriums.
right. That's exactly right. You could even have you could have AFib in the left atrium and flutter in the right atrium. They don't have to be the same. So this is a nice example of how the right atrium in this case is in fib, which is unusual, and the left atrium appears to be in some kind of uh, possibly an atrial flutter of some sort. So the atria don't have to be the same. And this is probably why sometimes, people used to have this diagnosis, fib flutter, where, it looks a little bit, I think we looked at a tracing a week or two ago like that. And in fib flutter, sometimes you see parts of the ECG where it looks like there's a fairly regular atrial tachycardia and then areas where it's not. And maybe maybe that's, maybe this is what's going on in the heart during those episodes, which is that maybe there is in fact flutter in one part of the atrium and fib in the other. So this is a nice example. So Mo, you're in the cath lab, you're doing an EP study and you induce this. You're trying to do an SVT ablation. So what would you do at this point if you saw this?
Mhm. I think sometimes it self-resolves and some you can shock the
That's
patient.
right. Sometimes it does. So particularly in kids who are healthy, I think if you do this in like someone my age, 58, pretty much you got to get cardioverted out of it. But I think in young people, more often than not, just as you said, when we induce this, the tachycardia will break on its own. So as long as the patient is stable, we'll often wait a little bit to cardiovert. Why is that better? If you knew, for example, that most patients were going to self-terminate, why would that be better than cardioverting them during an EP study, you think? I
Because
mean,
when
both
you shock,
ways the tachycardia stops, right? So,
yeah, it's just when you shock them, I think you can lose position of them, some of the catheters, and I think it messes up with the mapping too, because you
well,
lose the
yeah, I
position.
mean, that's right. So if you shock the patient, first of all, electrical shock is a myocardial depressant. So you essentially cause a little transient dysfunction, which, in most healthy people is not a big deal. But if you're doing an ablation in somebody who has, let's say, congenital heart disease with some dysfunction, or alternatively, um, you know, a, s- you know, just any kind of any unstable patient, you really don't want to be shocking them because you may take a stable patient and make them unstable, at least transiently. Obviously, again, when someone needs to be shocked, you shock them because the rhythm is presumably much more hemodynamically embarrassing than a shock. The other issue is that when a patient is shocked, it's not so much that the catheters move, although they could move. It's also that when you shock someone, you not only reset the myocardium, but you also stimulate the skeletal muscle of the chest. And so I'm sure we've all seen patients literally jump during electrical cardioversion. And when the patient jumps, the position of the patient on the table may be slightly different than it was prior to the shock. And the CARTO, or any 3D electroanatomical monitoring system, the other one is by Abbott, relies on the fact that the patient is in exactly the same position at all times because all of the location tags that are made in 3 dimensions are based on a model where the heart is not moving away from the location that it is at the time of the measurement. If you shock somebody, the entire body may move, and it may ruin a map or at least make the map markedly less accurate. And sometimes when that happens during a case, what we ask the technician from the company to do is to check the position of the pads. They can actually compare the location of the pads that are the localization patches on the front and back of the chest from the beginning of the case to the present time. And sometimes we see that they are not exactly in the same position. But even if they look like they're in the same position, remember that in Carto, for example, they guarantee that you'll be between 1 and 2 millimeters of reproducibility of the positioning. But if you shock someone and they move 6 millimeters, it's pretty hard to imagine that it's not going to affect the map. So For many reasons, cardioverting somebody, although generally a good idea when someone is unstable, of course, if they're not unstable, we would rather see the rhythm terminate on its own. So yeah, we would typically wait and see if this would resolve as long as the patient is stable in the arrhythmia, and also hopefully they're anticoagulated. All right, any questions about this? All right, this is a tracing that I received a few weeks ago. Hey, Rob, I know you're out of the office today. This patient, I think this was actually on Yom Kippur. This patient came to the ER after passing out from a blood draw and is still feeling weak. Are these block PACs or is this AV block? So, any thoughts?
Hi, Dr.
The
Pass.
P waves. Oh, sorry.
Oh, I see Christina's chatting there. Go ahead, Christina.
So looking at this rhythm strip, you know, there's a P wave before every QRS, but then not a QRS after every P wave. And then if I don't have calipers, but if you caliper it out, it looks like um the P to P interval is pretty regular. So I would say it's AV block as opposed to PACs. PACs, you would see the P wave or the cycle reset. And then the R to R interval is pretty regular in here as well.
So, what kind of AV block are you guessing here?
Mobitz, type 2.
Okay, so second degree, not
Yes.
first degree, right? First degree, every
Yes.
P wave would conduct with a long PR. Not third degree, because it does clearly, there's some RR variability and there does appear to be conduction, at least sometimes. And, part of the thing that helps us with that is that the PR looks very similar on the beats that are the P waves that are followed by a QRS. So it doesn't feel like this is just isosynchronous beating, right? Isosynchronous meaning that the atrium and the ventricle are just beating at exactly the same rate, and it gives the appearance of conduction. Now, it turns out that this P wave is actually early, but this one is not. And I mean, this is at a rate of like 120 from this P wave. And so this should conduct, right? Actually, I think I put these two little markers here that these two P waves were worrying me. So yeah, I think this is an example of Mobitz 2, or sometimes you would just say high-grade second-degree AV block. And what would you do about this? At the time that this was seen, this was a tracing that was sent to the doctor from the emergency room. And then by the time that they sent it, the conduction recovered and the patient was conducting one-to-one. And they even had, luckily, an old electrocardiogram on this patient for some other unrelated reason that was completely normal, with a normal PR interval, normal QRS duration, normal axes and forces. So what do you think about this? The ER is calling you and wants to know, what should I do about this patient?
I think I'd be a little worried to send them home after this episode. I know, I don't know if there's a history of having prior episodes of being syncopal or pre-syncopal, but
Patient does complain of some dizziness getting out of the shower intermittently. Has never frankly fainted, although has nearly fainted a handful of times.
yeah, I'd want to, observe them on telemetry overnight to see, how often they're having these episodes, and also would want to get an echo just to look at the function as well.
Why do you want to look at the function? What are you worried about?
Worried that the function, one could be depressed if there's AV dysynchrony, and then, also would want to rule out structural causes that could contribute to the development of heart block.
So this is a teenager. So what's the chances that someone has a structural heart problem that has not been diagnosed by, age 14?
Pretty unlikely.
Pretty unlikely,
Yeah.
right? And AV block does not generally cause dysfunction, right? It causes, now, certain forms of dysfunction, though, can cause AV block. What's one that we think about?
Like a cardiomyopathy.
No,
Could
cardiomyopathies don't usually cause block. I mean, you can have block with cardiomyopathy, but is there any acute disorders that cause heart block and dysfunction?
like a myocarditis.
Yeah, myocarditis or even endocarditis. Both of those could be associated with heart block. So any testing you would want to do in the emergency department that could be done by the ER and not require you as the cardiologist to come in and do something?
Do like troponins.
Right, you can get troponin. What else would you get?
Get
Troponin, presumably
yeah.
looking for cardiac injury from some kind of inflammatory process, right?
Yeah, and inflammatory markers as well.
Yeah, so you'd get a CRP or an ESR or something like that. What else could cause a block of some sort?
Like a Lyme disease. You could get Lyme titers.
Right, you can get Lyme titers, although usually, unfortunately, those take a while to come back. But yeah, you would probably send that. That's easy enough to do. Any other causes of a block that are medical? Any endocrinopathies affect this?
Like hypothyroidism. You could
Yeah,
get
hypothyroidism.
TFTs.
Yeah, I would definitely get TFTs in somebody like this. And then you would also want to take a history, make sure there's been no ingestions, right? Especially in a teenager with mental health concerns in general for teens. I want to be sure that patient hasn't ingested something that could cause heart block. So in this case, I think what happened was, you can see this type of block in somebody who is having a neurocardiogenic syncope. And so, although I would certainly not say this is normal, since it had resolved very rapidly, this was just from a rhythm strip that the nurse astutely printed out in real time in the ER. The decision was made to do all that blood work, which was all negative, and to observe the patient in the ER for a few hours. And during those few hours, when the patient was hydrated and was feeling better, there was never again a drop P wave. And so the patient was discharged to home with follow-up the following day by the cardiologist. And at that time, the evaluation was negative, including an echocardiogram, as you had suggested, Christina. And a Zeo patch was placed, and I don't think we have those results yet. So, yeah, I mean, I think no one would ever argue with the decision to admit somebody like this also would have been perfectly reasonable. This was at a community hospital, though, and so I think because telemetry was more challenging there, because there was a very negative history, no history of sudden cardiac death in the family, no history of syncope before. There was some electrolyte evidence that the patient was dehydrated. They decided to treat this as a neurocardiogenic episode, and the patient got better and thankfully has not had a resolution. But this is interesting tracing. Okay. All right. Let's go to this one here. So this is atrial pacing at cycle length 530. So cycle length 500 is a rate of 120. So this is like a rate of 115. And they have labeled the tracing for us. So what do you think is going on here? And let me just, so these are 3 surface electrocardiogram leads, leads 1, 2, and 3, and actually a 4th one, V1. This is a high RA, and then this is a Hiss bundle electrogram. So one lead of the Hiss. And these numbers, in case you can't see them, is 130, 140, I think maybe it's 142, 150, 165, etc. Any thoughts?
Mm-hmm. And this is atrial. Okay, it's written there.
Atrial pacing, yeah, it's a
Yeah.
ugly looking surface electrocardiogram, but it is, that's why I kind of think it's important to tell
Okay,
you.
so just
a pacing.
so looking at the surface EKG to get an idea where the V is, I think, and then looking at the Hiss, I think the AH interval has been like the same for all the beats, but the HV is
So this, okay, say that again. The AH is what?
I think the AH interval
Yeah.
is,
I think you said it right. I just wasn't listening carefully
yeah,
enough.
I think it is just it looks like the same to me, but the HV is progressively increasing.
Yes, that's right. So what do you think? What would we call this then? I mean, if you look at the surface, right, you have paste to QRS, paste to QRS, paste to QRS, paste to QRS,
yeah, so essentially the
paste.
PR is prolonging, so it's decremental conduction.
Okay, so when the PR is prolonging and then you have a pace beat and no QRS, what do we
Oh,
call it?
I'm sorry. Yeah, yes, I didn't see this. So it's wonky packing, and then it's the effective refractory period of the AV
Well,
node.
no, what do we call this when we what cycle length is this when the PR gets longer and longer and then it blocks?
So this is the effective refract, right?
No, the effective refractory period would be when we're doing extra stimulus testing. This is straight atrial pacing at 530. I think you're on the right track. You're just using the wrong terminology.
I'm sorry. It's I was muted. So it's wonky backing, and it's blocked, right?
Right, it's wanky bocking, exactly. So as you guys know, when you've been involved in cases with me in the lab, one of the first things that I choose to do in every patient once all the catheters are in place is to pace the atrium to see what the wanky box cycle length is. That's sort of a very quick way to confirm that the AV node is conducting normally with normal AH and HV intervals. And also, it's a very useful thing because in the end of the case, when you're burning and blading near the AV node, it's nice to know what the node looked like at the start so that you're aware of if you've potentially injured something, which obviously we're always trying very hard to avoid. So you want to know what you're starting with. If, for example, I saw this at the start of a case, I would be very, very concerned. When somebody is wanky bocking, do we normally believe that to be suprahissian or infrahissian?
So I think it's infrahissian because it's the HV that's prolonging.
Well, in this case, it is infrahissian. I agree. The HV interval is lengthening.
But usually it's the AV node, so it's suprahissian.
Right, it's usually the AH interval. Remember that the AH interval is supposed to represent conduction in the AV node, and the HV interval is supposed to represent His-Purkinje conduction. And so when somebody is wanky bocking normally, in the majority of cases, the problem or the lengthening is in the AV node, which is represented by the interval between the low right atrium A and the His bundle deflection. This is an unusual tracing in that we're seeing lengthening in the HV. That's also, by the way, why the QRS is so strange looking, because there's a lot of, aberrant conduction or slow conduction through the His-Purkinje system and then block. And so this is distinctly abnormal. Also, what do you make of somebody who wanky box at cycling 530?
But the AV node is not healthy.
Yeah, this is a very bad AV node. Presumably, one of the reasons this study was done in this patient, and this is from a very old textbook, was because somebody must have seen this patient both with this very strange looking QRS and wanky bocking at very long cycle lengths or very slow heart rates. So this is somebody who has very significant conduction disease. In this case, it's His-Purkinje disease. If you saw this, so in the old days, they would do lots of EP studies for stuff like this. So this is what you find. What do you think? How would you treat this? Patient is having occasional syncopal episodes.
Oh, you mean outpatient, not in the lab?
Well, I mean, the reason you brought the patient to the lab is because they're having syncopal episodes. You bring them in, you see a lot of wanky bach. It's very ugly QRS duration. What would you do then? So you take them to the lab, and this is what you see. You see this, you're seeing infrahissian wanky bach, which is, again, unusual.
Yeah. I mean, if
I'm sorry, did you say something, Mo?
no, I'm just thinking. I think I'd probably do like a ZU and a stress test, and then see if they're very symptomatic. And
Right. Well, you could do that. I mean, basically, what you see is tons and tons of wanky bach at a cycle length of like 530. So this would probably be an indication for a pacemaker. This is a very AB normal conduction, having such profound infrahissian disease as this, with wanky baching at such a long cycle length as this. You could try giving the patient isoprel to see if maybe at a higher adrenergic tone there is conduction in the His-Purkinje system that improves. But what could happen actually is all that may happen is the sinus node improves, but the His-Purkinje just, is strained even more. You might even paradoxically see more block because there's maybe a fixed injury to the His-Purkinje system. So this is a very abnormal tracing. It's an unusual tracing, which is why I'm showing it. I showed it once before to this group back in May, but I think it's worth seeing again, just to remind everybody. So normally, as we get faster and faster, we would observe the A to H interval prolonging with the HV relatively constant, because the HV doesn't usually decrement like this. It does decrement, but not to this degree and not at this long of a cycle length, 530. In general, of course, that when we do these cases in children, they're under general anesthesia. And some of you have heard me say this, but the general rule of thumb when you're under general anesthesia, in my experience, is that everybody should be able to conduct 1-to-1 to cycle length 400. If they're not, that usually means either they're under very deep anesthesia, they have extremely high vagal tone because they may be very, very well-trained athletes, or there is an injury to the AV node. But you really need to figure out which of those situations you're dealing with before you start ablating. It seems almost always that when you encounter somebody who has a long wanky bach cycle length at the start of an EP ablation, it always seems to be that they either have a paraseptal pathway or they have AV nodal reentry, and you have to be burning right around that area. So it can be pretty scary. I've told the story here before that one time I saw a patient who was a Division I 800-meter runner for Villanova. This is about 20 years ago. And he came into the office with the history of SVT and documented. And his resting surface electrocardiogram was a heart rate of 37, and he was wanky baching at 37 beats per minute with a very long PR interval. And I'm thinking to myself, this is going to be a very scary ablation because already, because of his profound vagal tone, his AV conduction was being affected. That's a healthy form of AV nodal slowing. So interestingly enough, he had already been consulted on by another very good electrophysiologist, and I recommended they just stay with the person they went to. I was really more of a second opinion. And I came to learn that they used cryo in that case because they were so scared about the AV conduction that they wanted to be sure that there was at least some element of reversibility while they were delivering ablation lesions in that patient. And apparently it was successful. So, all right, I think we'll stop here. Thanks for joining, everyone. I hope everyone has a great day. Take care.
Thanks, Dr.
Thank you.